me okay? Thank you. My name's Ray Jones, and I'm the atrial fibrillation program coordinator at Atrium Navicent Healthcare in Macon. And we really appreciate you having us here today. We think it's very important that we get these opportunities to get out and provide this information that can empower you to make decisions on your health care that can have a big impact on your life down the road. So we appreciate it more than you know. Thank you very much for that. And what a beautiful campus you have here. I got to tell you, this is absolutely gorgeous. And what a wonderful job you've done coordinating and planning the whole thing. It's, everybody's been so nice, super nice. Everything's going together really well. So congratulations on that. So we're here today to talk about your heart, atrial fibrillation specifically, and what a wonderful organ your heart is. I've been in cardiovascular services for a long time, and it never ceases to amaze me the things that we know about the heart and the things that it does. It's always sort of occurred to me that your heart is sort of similar to a house in a way. A house has different rooms in it, your bedrooms, kitchens, living rooms. Your heart has different rooms. It has your left and right atrium, left and right ventricle. The walls in your house are made out of wood or steel or some other material. The walls in your heart made of muscle, but not just any muscle, and this is important. It's made from cardiac muscle. It's different from skeletal muscle, and I'll come back to that later, but that's very important. Your house has plumbing. Your heart has plumbing. It has arteries, it has veins, and you can have trouble with arteries and veins, just like the plumbing in your house. If you have trouble with the plumbing in your house, you call the plumber. If you have trouble with the arteries in your heart, you'll call an interventional cardiologist. And if there's an issue, we can take you to the cath lab, and we can unclog your arteries or repair them. Your house has an electrical system. And if you have a problem with the electrical system, you call an electrician. Your heart also has an electrical system. A lot of people don't realize that, but it does. And if you have an issue with your electrical system in your heart, you call an electrophysiologist. And that's the doctor that will take care of that. Now, the electrical system, any number of disorders that can occur with it, the one we're here to talk about today is called atrial fibrillation. Has anybody ever heard that term? Does anybody here have atrial fibrillation? So we have an expert on the topic. So I put together a short presentation today to try to explain to you. It's a pretty difficult thing to explain, but I hope I've done a good enough job to get my point across. It'll take about 20 or 30 minutes. Then afterwards we'll have a little test. I'm kidding about the test. So what is it? Atrial fibrillation is an abnormal rhythm of the heart. It's relatively common. It affects about 2.3 million adults in the U.S. every year. And the prevalence increases with age. Most people who have it are over the age of 65. Most people. Talk about that a little bit more later. Just a quick overview. Atrial flutter is a related disorder. It's very similar to atrial fib. You can have one, you can have both. And it overlaps with respect to mechanism, management, and prognosis. And again, you can have one, you can have the other. The rhythm I have up there is what atrial flutter actually looks like on an EKG, if you're interested. So what is it? Normally, every heartbeat you have is generated by one cluster of cells in the upper right chamber of your heart. It's called the SA node. I always look at the SA node as like a spark plug. That one cluster of cells fires like a spark plug. It creates an electrical current, and that starts the entire system. And your heart normally will beat in a coordinated fashion. The top part, bottom part, top, bottom, is the lub-dub. That's what you hear. Normally, it's very coordinated, no issues. In atrial fibrillation, we said cardiac muscle, remember that? The important thing there is any cardiac muscle cell can generate an electrical current. So if any cell in your heart can generate an electrical current, then you got the potential to have any number of spark plugs, right? Well, in atrial fibrillation, that's kind of what happens in a way. You've got more than the one spark plug. So Instead of the one, you may have a dozen, you may have 2 dozen firing. Look at it like your lawnmower. You pull the cord, the spark plug fires, and the engine runs. Imagine if you had a dozen spark plugs. That thing would run it would run horribly, right? Well, that's what happens with your heart. It flutters. It doesn't beat efficiently. So the upper chambers of the heart, they don't work correctly. So the atria quiver or fibrillate instead of contracting normally. They don't really pump. So the blood's not moved out of the atrium efficiently. Well, what happens to blood when it's not moving? It clots, and that's the problem. We'll talk a little bit more about that in a few minutes as well. It adversely affects the pumping action of the heart, and it makes you feel very poor, usually, but not all the time. It can lead to clot formation and increased risk of stroke. Atrial fibrillation has a 5-fold increase. If you have AFib, you have a 5 times risk of having a stroke. I'll tell you why in a few minutes. There's 2 basic types of AFib. The 2 we're going to talk about today are paroxysmal. Paroxysmal means intermittent, so you may have it now. 2 minutes later, you may not have it. It comes and it goes, which is part of the challenge on our end in identifying it. You may have AFib at home, have the symptoms, and go to your physician or go to the emergency room. And by the time you get there, it's not doing it. It's just like your car. It's making a noise. You go to the mechanic. If it's not making a noise, you can't figure out what it is. And there's persistent AFib or chronic AFib. It's continuous for at least 7 days. And it usually requires efforts at restoration of a normal heartbeat. Paroxysmal AFib is usually resolves on its own within 7 days. Now, we loaded a little video. I hope it will play, if we can go to that. Flip it. This is a pretty good illustration of atrial fib. You'll notice in the very beginning, you can see this SA node right here. It's the pacemaker. That's your spark plug. That's where your heartbeat normally generates from. And the electrical current goes out through the rest of your heart from there. You can have the sound.
Pushing blood out of the heart, into the arteries, and out to the body and the lungs. In AF, a malfunction of the pacemaker interrupts this coordinated sequence of contractions, causing the atria to twitch erratically, known as fibrillation, and the ventricles to contract more often and irregularly.
That's a pretty good illustration of what it looks like. Thank you for playing that for me. So what's the cause of atrial fibrillation? A lot of different causes. Increased age, we already said most people that develop it are 65 years of age or older. Most, not all. We see many patients in their 30s, some in their 20s. With COVID, we're seeing patients even younger and more younger patients. So COVID has had an effect on people coming down with atrial fibrillation. Underlying heart disease due to high blood pressure or pretty much anything else. A prior heart attack, because with a heart attack you can get scarring and that can interrupt the electrical circuit. Heart failure can cause atrial fib. Atrial fib can cause heart failure because that muscle isn't beating the way it normally does. It loses its tone. Heart valve disease, see a lot of atrial fibrillation caused from a faulty valve. Such as mitral valve or with mitral stenosis. Diabetes is a big risk factor for atrial fibrillation. Chronic kidney disease, complication of heart surgery. Alcohol, binge drinking can be an issue. If you're just a person that drinks occasionally, I've known people that would have a couple of drinks, of wine, a couple of glasses of wine or a couple of beer, and they get atrial fibrillation. They could quit drinking and the AFib goes away and they never get it again. That's okay for those kind of people. Other people have more trouble letting alcohol go, so it's an issue for them. It's not as easy as it sounds for some people. Hyperthyroidism, Some medications, in particular, there's one called theophylline that can cause atrial fibrillation. Sleep apnea is a big risk factor. If you don't know what, do you know anybody that snores? Yeah, me too. We like to yuck it up about people snoring. It's fun to have a joke about it. It's a little more ominous than that. When you're snoring, your airway is getting obstructed. And with some people, if it's obstructed sleep apnea, then your O2 saturation drops. And that can cause heart failure over time. So I encourage you, if you know a person that snores loudly or bad during the night, go to a sleep specialist. Let's identify it and deal with it. There's things we can do to correct that. Obesity, big risk factor. Smoking, huge risk factor for AFib. If you notice, a lot of these factors are controllable. If you can identify it, then you can cut it out and you can do away with your atrial fibrillation. Talk a little bit about symptoms. Some patients have no symptoms. It's weird. We see patients, it's an AFib, and it just completely wipes you out. You just feel completely wrung out. You don't have the energy to do anything because that heart's not beating well. Some people never know it. It's just a very strange thing. So people have mild symptoms, and some of those could be unpleasant palpitations. Your heart flitters and flutters. You can feel it. Some people do, some people don't. Many people do. That's the reason for many ED visits where we first identify it in a lot of people. Some people perceive it as mild chest discomfort, a sense of the heart racing because the heart is racing. Sometimes your heart rate can get up into the 150s, 160s, and you can imagine what that would feel like. Very, very uncomfortable. Mild shortness of breath, fatigue, especially with exercise, again, because that heart's not beating efficiently and it's not pumping blood. Some of the more severe symptoms are difficulty breathing, especially with exercise. We see people present frequently as completely out of breath. Fainting, near fainting due to reduced blood flow. Also, if you go into, or in a normal sinus rhythm, a normal rhythm is called sinus rhythm because it originates from that SA node, your spark plug. Sinus rhythm is a normal rhythm. If you're in a sinus rhythm and you go into atrial fibrillation, or if you're in AFib and you go back to sinus rhythm, sometimes your heart rate will drop quickly, and that can cause an episode of passing out or syncope, and that can cause injury as well. Chest pain, severe fatigue. People who are in AFib frequently have the energy, just don't have any energy for anything, just really severe fatigue. So what are the complications? Numerous. I want to talk about two mostly today. Stroke. We said if you're in AFib, you had a 5 times risk of having a stroke. Over 90% of all embolic strokes, if you get a blood clot that's causing your stroke, more than 90% of those are caused from a clot from AFib. The clots come from an anatomical feature in your heart. It's called the left atrial appendage. Has anybody ever heard of the left atrial appendage? It's kind of a strange little critter. It's a little pouch that hangs out on the side of your atrium. It's just a little pouch. Just sticks out there for years. We really didn't know what purpose it served. God don't put anything there without a purpose, though. It does serve a purpose. When you're in AFib, the blood tends to clot within that atrial appendage because it's not being pumped out efficiently. Remember, we talked about that. That's where these clots come from. Heart failure. If that muscle in your heart isn't working the way it's supposed to, it's like any other muscle in your arms or your legs or anywhere else. If you don't work it, then it loses tone. Your heart muscle's the same. If it's not working efficiently, if it's just fluttering, then it loses tone over time, and it can cause heart failure. Diagnosis and treatment. We have to have an EKG to identify it conclusively, or a Holter monitor. We said earlier, sometimes people will have these flutterings in their chest and they'll go to the ED. Well, it's not doing it. Well, we understand that. So sometimes we will put a Holter monitor or an event monitor on that stays on. It will record your heart rate and rhythm for 10, 30 days, sometimes longer. And you will take that back to your physician and they'll review it and they'll see if you were in AFib, and if you were, what your AFib burden was. And that frequently is how it's diagnosed, and then we kind of go from there. But we have to have that electrical tracing to identify it. You know, we talked about all these symptoms and all, and just based off of what I told you, I bet somebody out there right now thinks you got AFib. There's other things that can cause these palpitations. There's PAC, premature atrial contractions, premature ventricular contractions. Every flittering and fluttering that you feel in your chest is not AFib. So how do you know? Well, the answer is you don't. Nobody knows. You know, unless we get you hooked to a monitor and identify it, there's no knowing. But if you're having the symptoms, I encourage you to go to a physician and look at it on an EKG, and let's figure it out. It doesn't have to end this way. We can correct these things, but you have to listen to your body and act on it. But how do we correct it? You know, sometimes initially we do an electrical cardioversion to get you out of AFib. The longer you in it, the higher your risk of having a stroke from a clot. And it doesn't take a tremendous amount of time. It's hours or days of being in AFib, and you are at really high risk of having a stroke, so it's critical that you act quickly. Sometimes we'll do an electrical cardioversion. You've probably seen it on TV. They put the pads and they say clear, hit the buttons, and it shocks you. We do it at a very low voltage or joules. Is what we go by, and we reset that heart rate. So we shock it, and it resets the heart rate. Sometimes it works, and sometimes it doesn't. Sometimes we will convert you back to a sinus rhythm. It'll last a few minutes, and you can go back. Sometimes it lasts for a good while. Sometimes it doesn't come back. But that's the first line of treatment to get you out of AFib. We also use medications. There's medications called antiarrhythmics. There's cortisone, flecainide, Tambicor, a lot of different ones that can help you not to go back in atrial fib. Treatment. Treatment is basically two things, rhythm and rate control. The two main things we need to address is rhythm and rate. So we try to get you out of it. We try medications to keep you out of it, and then beta blockers and that kind of medications to keep your heart rate down. Sometimes we can't get you out of it. In that case, rate control is most important. Cardioversion is first line, antiarrhythmic drugs. There's a procedure called an ablation procedure where we go in through the groin and we go up into your heart. And we've got these incredible machines, believe it or not, that can track that rhythm down, and our physicians can ablate it. And to use a complicated medical term, and I hate to do that, but we zap it. We find it and we zap it. It's not a burn, it's an ablation, but it just kind of zaps the spark plug that's causing the arrhythmia. And sometimes that corrects it. We have great success, more success now than we did in years past because of an improvement in our equipment. Always there will be anticoagulation therapy to go along with both of these treatment modalities. Rate control, there's beta blockers, calcium channel blockers, and a drug called digoxin that will keep that rate down. Either way we go, we're going to always have to go with it. I'm not sure what that was. With anticoagulants. Some people, I told you about the catheter ablations. We can use heat or cold for that. Frequently, we'll have to use a pacemaker. It's usually when we're not able to convert you. The pacemaker doesn't pace you out of AFib. What it does is senses your heart rate, and when you go from AFib back into a sinus rhythm or sinus rhythm to AFib, and we talked about it earlier, your heart rate can drop and cause a syncopal episode. The pacemaker will sense that, and it'll pick your heart rate up to keep you from having these episodes of passing out and injuring yourself, but it will not pace you out of AFib typically. Everybody knows what a pacemaker is, right? It's a little device that we implant, and it will deliver just a small electrical shock to replace your natural spark plug. And we have to use those frequently. There's another procedure I don't like to spend a lot of time talking about. It's called a Maze procedure. It's never done alone. It's if you have to have open heart for a valve or for bypass anyway. If you're having trouble, we go in and do this Maze procedure, and we put this thing in there. It looks like a spider web sort of, and it allows us to burn at a more controlled rate and depth. The atrium is very thin. The risk is burning through it. With the Maze procedure, we can visualize it because we're already in there, and it's very successful, but it's never done as a standalone procedure. We already talked about the risk of stroke from blood clots in the left atrial appendage, and the anticoagulant drugs. Some people are not a candidate for anticoagulant drugs. Anticoagulants are the most successful at reducing the risk of stroke. They're 70% successful. Some people, because of an ischemic stroke or other reasons, they're not candidates for anticoagulation therapy, but it's critical that we address that because that's a huge factor in atrial fib. For those people, there's a device that's called a Watchman, and I think I have a slide that kind of shows it. It looks kind of like a small net or a small umbrella, and we go into the little atrial appendage and open that up. You'll see it in the top right. That's what it looks like. And if there's a clot in there, this device keeps the clot from coming out. It works immediately, but over time it endothelializes. The tissue will grow around this little fine wire mesh, and it completely seals off the left atrial appendage. We're having a lot of success with this device. Again, everybody's not a candidate for it, but if you need it, it's a really good option. So we talked about a lot of different things today, and we talked about the symptoms. The message, the take-home message is you have to listen to your body. We talked earlier about you maintain everything else in your life. You maintain your house, your lawnmowers, your sons, your daughters, your husbands, your wives, your pets. You take care of everything in the world, but when it comes to yourself, people tend to ignore these symptoms. And it's scary. It's only natural to be scared. We can fix these things. You need to listen to your body, and let's go get it checked out and find out what it is. And a lot of these risk factors are controllable. You can cut out. You can lose weight. You can quit smoking. You can quit drinking. You can control your diabetes. A lot of different things you can do that possibly can eliminate your atrial fibrillation completely. But you have to identify it and seek treatment for it. That's the extent of my little presentation. I hope I've done a good job in explaining basically what AFib is. I appreciate everybody coming. Thanks for having us so much. If you got any questions, I'd be glad to stick around and try to answer them for you. Yes, ma'am. No, ma'am. Over time, that thing is endothelialized. Your body grows tissue around it. It's kind of like if you've probably seen a fence nailed to a tree. The tree grows around it. Your tissue grows over that mesh, and over time, it just seals it up. It's not removable. It's kind of like a stent. We put a stent in your arteries. It doesn't come out. It doesn't need to come out. So the answer is no. Anybody else? Well, again, thank you so much for having us here today. It means a lot to us. We're doing a screening over in the other building, and if we need to, we'll do a full 12-lead EKG. Again, thanks for having us.